Welcome to the last day of the Skoll World Forum and this session, the Impact Jackpot, Service Delivery Innovation for the Very Poor. I'm KRISTIN GILLISS. I'm Associate Portfolio Director at the Mulago Foundation, and I'll be your moderator today. Mulago is a private foundation in San Francisco that invests in organizations with a high-impact, scalable model to address basic needs of the very poor. So I spend a lot of time thinking about this topic. For the very poor, access to basic services is often not about moving out of poverty, but it's about survival. So we spend a lot of time with organizations exploring the right actors, subsidies, and distribution channels to actually get products and services that are high impact to the very poor. And that's the topic we'll explore today with our speakers. So part of my job as moderator is, of course, to ask scintillating questions. But that's your job, too. So please know that our panel is really interested in having a conversation versus presentations this morning, and we hope all of you are as well. So before I introduce our speakers, we actually wanted to have a bit of a sense of who's in the audience this morning. So we assume you're at minimum interested in this topic, but we'd like to know if you could raise your hand if you're actually directly involved with distribution of products or delivery of services that address basic needs of the very poor. Okay, great. So keep them up if you think you do it well. Okay, so keep them up if you reach at least 1,000 people with your services. Okay, if you reach 10,000 people. 100,000? 1 million? Great. Okay, well we should have had a lot of hand raisers at the front of the room as well, but it's great to have a sense of the type of work people are doing and how you're thinking about scale. So to introduce our speakers this morning, first we have Steve Davis. Steve is the president and CEO of PATH since June of 2012. PATH works across sectors in more than 70 countries to get health innovations to the hands of people and communities where they're really needed. PATH was a natural step in Steve's career, given a lifelong commitment to human rights and equity in global health and development. He has been a technology business leader, director of social innovation at McKinsey, and an intellectual property lawyer, but always a health and human rights advocate. So we're happy Steve is here today. Andrew Yoon is the director and founder of 1 Acre Fund, which helps smallholder farmers increase their productivity. With good cause, they are the darling of the social entrepreneurship space, growing by 50% per year and now in 4 countries in East Africa, working with 200,000 farmers. Thanks, Andrew, for being here. Live from the headquarters of 1 Acre Fund in Bungoma, Kenya. It's an honor to have Dr. Christine Kasiba, First Lady of the Republic of Zambia, here today. It's really important for this session to have a voice from government, but particularly hers. She, as a doctor, has been a passionate advocate for the health needs of women and children, and we're really looking forward to hearing what her perspective on this topic is this morning. And NEAL KENY-GUYER joined Mercy Corps as its CEO 20 years ago. It is one of the leading international humanitarian and development organizations with operations in more than 40 countries, a budget this year of more than $400 million, and working in not just tough places, but maybe the toughest, including places right now like Syria and its neighbors. At its core is helping those communities in tough places move often from crisis into opportunity and resilience. So we're glad to have NEAL's perspective as well today. So I want to frame our conversation this morning by just showing a quick 60-second video that I think captures our target population we're talking about and also provides some insight into 1 Acre Fund's model for service delivery. So we can, it's short.
Africa's farmers are some of the hardest working people on the planet, but they live in remote places and have little access to resources. Their crops are failing. We change that. 1 Acre Fund provides smallholding farmers with exactly the resources they need to succeed. We provide our farmers with seed and fertilizer on credit, we deliver to their doorstep, we train them, and help them sell their harvests. All of these services need to be provided together. Without credit, seed and fertilizer are unaffordable. Without training, farmers do not use their resources properly. And without delivery, these services may as well be on the moon. We provide all of these services together, and on average, our farmers double their farm income per acre and build a path out of poverty. Most of Africa's poor are hardworking farmers. We provide exactly the resources they need to achieve a better life and to eradicate hunger in their communities. We only serve farmers, and we always put farmers first.
So just to underscore how seriously Andrew takes being the voice of the farmer, he's actually the one narrating that video as well. So Andrew, 1 Acre Fund is now identified with successful last mile distribution. And that video essentially puts forward an equation that says the synergies of that bundle of services is what leads to impact for farmers. Where's the innovation here? Is 1 Acre Fund doing something different, or are you just executing something really well?
We really believe that distribution and delivery have to do with multiple barriers, and so we take multiple very boring interventions and combine them together. So the way a barrier works, obviously, is that if there's something blocking you from success, even just one barrier, you can't reach success. So that's why we believe that distribution and delivery is about product curation, so configuring products in a way that's appropriate to the target population, and obviously that are actually impactful. Physical delivery is very important. So what we do is we aggregate, we purchase with the power of 200,000 smallholders, aggregate into warehouses, and then organize like more than 1,000 distribution drops in just like rural schoolyards and people's houses and that kind of thing. We think that affordability is very important, particularly for economic goods. So for example, in our model, we provide credit. And then lastly, training. In many cases, it's very, very important to accompany life-improving goods together with how to actually use them properly and get the most bang for the buck. So I think what's unique is not particularly unique, actually. It's very boring, but we combine 4 things together into more of like a holistic package.
With the farmer in mind from the start.
Yeah, farmers first in everything. Absolutely.
So Steve, PATH is so well known for its impact in the vaccine space, but products don't deliver themselves. So when you think about the product of the vaccine, how from the beginning are you thinking about the vaccination that has to happen? Are you thinking of government? Are you thinking of the health worker? Are you thinking of the patient? Or none of the above?
It's a pretty, as you might imagine, complicated ecosystem, but just, you know, PATH is very much focused on social equity, and that's really, we believe that, and has for 40 years believed that it's about providing, sort of addressing the inequity in health that will be a core piece of helping countries develop and move out of poverty. And therefore, what we do is across 5 platforms: vaccines, drugs, diagnostics, tools and devices, and then a lot of work on social and service innovations. And so sort of, and in some ways that last platform is the most important, despite the fact that we've, you know, developed enormously successful vaccines that are affecting hundreds and hundreds of millions of people. But the work on, okay, what is the behavioral change issues and what's the social science behind that? What are the pricing and market dynamic opportunities to sort of accelerate? So when we start thinking about an opportunity to address a problem by evaluating our potential impact in terms of really very clear metrics around, you know, can we get to hundreds and hundreds of millions of people, we start thinking about clearly the science and the scientific pathway, but also the regulatory pathway if it is a product. We think about the, you know, very much who's the ultimate recipient and how are they going to actually engage with the product and use it. We do a lot of work on, uniquely so in some ways, on costing at the very beginning. So a meningitis vaccine, for instance, that we've rolled out across with UNICEF and WHO across northern Africa, or sub-Saharan Africa, the northern part of sub-Saharan Africa, which has hit about 150 million kids in the last 2 years, and nobody's gotten sick, so it's a big success. But we actually, the big issue there was we insisted with the various pharmaceutical partners that it be at less than 50 cents a dose in order to push this forward and do the clinical trials. And that having the price as part of the target product profile was the most critical thing we could actually have done to make this a successful project.
Interesting. So I know before you joined PATH as CEO, you had been on the board for many years, but you also worked as interim country director in India for a while. And I found an interview where you talked about how that was influential in the way that you think about global health. So you said something that I thought was really powerful. You think about big strategies and PowerPoints, and we need more than that to understand what's going on. It translates differently when you deal with bureaucrats, crazy political moves, people dynamics, and state-by-state issues. Things look different from the ground. Can you talk a little bit about how you try to maintain perspective today of what's happening on the ground to inform your work?
Yeah. Well, first of all, I think I was probably particularly at that moment affected by, I was straddling two different worlds. I was leading one of the big practice areas for McKinsey, so I was like sitting in Geneva with PowerPoints and analytics 1 minute, and then I was suddenly, you know, on the ground in Bihar, sort of trying to figure out how you solve a problem the next minute. So I was particularly realizing the gap was huge. I guess there's two things I would do. One is I sort of framing it. I think the challenge we're having, and I would say right here at the forum we need to think about, so we celebrate and talk a lot about early innovation and social entrepreneurs, and then we are now beginning, you know, there's a fair amount of attention being paid globally and here to the last mile. And the problem is there's a huge distance between those two things. And we're not actually talking about that enough, investing in that enough. How do you build evidence? How do you adapt? How do you get the environment right? How do you do the advocacy work? How do you get across, you know, regulatory hurdles? How do you get it endorsed in a curriculum? How do you get design distribution so you actually can learn through operational research what works and doesn't work? And so one sort of, I think, important message is thinking about that is really, you know, key to forcing your mindset to think about the customer and the consumer and the, you know, and the country. I think, you know, just in terms of practical things, I spend a good third of my time in the countries we work deeply. You know, we hire people around the world, scientists, doctors, lots of leading people, but we're increasingly, the footprint is outside of the United States and Europe. It's very much about finding and tapping into innovation around the world, and that's where we're seeing some of the most interesting new products come out of, you know, that we just did a very interesting project around maternal, since MDG5 is such a challenge and we're seeing so many maternal deaths, and a good example is, you know, what a midwife does in a rural clinic to address postpartum hemorrhage. And they often sort of force, you know, kind of a condom or a balloon to stop to blanch this. And so we've actually created a very cheap, lower than $4 a unit tamponade that is actually robust, culturally appropriate. It actually can be reused, et cetera. And so we're really and the way we designed that was really by spending time in clinics. I mean, not me, but our teams in clinics with midwives, watching how they jerry-rig things and say, well, can we help you go beyond the jerry-rigging and create something more sustainable? And I think us thinking through those lenses is really important.
Great, thank you. So Neil, since we're in Oxford, it seems appropriate to use an obscure 5-syllable word. So I have to describe you, and Steve as well, as a peripatetic CEO.
And move around a lot.
It means, and I think everyone should use, this should be the word of the day today, and everyone should use it. But yes, it means traveling from place to place, a traveler from place to place. It also means an Aristotle-like philosopher. Oh. So, so given the combination of those two things, can you speak a little bit about, after 20 years at Mercy Corps, like, what is your perspective now on service delivery and how to continue to push the frontier?
Oh my goodness, I'm gonna, yeah, I have to then wax obscurely, right? No, I will say, so maybe two things that are simple that maybe are a little bit counterintuitive. And I think, you know, after 20 years, and I would, well, first, good morning, everyone. Great to see you, and great to feel this energy and be among such talented people. I'm honored. Thank you. You know, the first, I mean, I've been a big proponent of the, you know, we have to bring innovation to that. We have to look at new business models. We have to have the rigor and discipline that the 1 Acre Fund sort of represents. We've got to, you know, leverage technology in powerful ways, the way PATH does and so forth. But at the end of the day, there is something, that, you know, those fundamentals in some sense that I started out with a long time ago during the killing fields of Cambodia are still true. And that is that for anything to endure and be sustainable, it has to be owned by the communities. The communities of people are always the best agents of their own progress, of their own recovery. And that's still true today and will always be true, I think. And secondly, that, you know, really big change, moving needles, to me is always about partnerships in the sense that it is, you know, it's always in some sense bringing together government, bringing markets, private sector, and bringing community together. And when you can do that, you know, in ways that are transparent, in ways that are inclusive, in ways that promote mechanisms for peaceful change, that's when big things happen. You know, you need things that point the way. You know, you need the partnerships at the grassroots. But ultimately, community ownership and then partnership among the sort of holy triangle of the three sectors, critical.
So I've heard you speak recently a lot about convergence, which you talk about in a way that's different than collaboration. Can you talk about what convergence means for distribution channels to actually reach people?
Yeah, and this group, I mean, so many people here really practice that. And, you know, convergence is I think you are seeing, you know, in big part because of technology, but this, you know, we're all becoming agnostic in terms of the form of service delivery. So we're for-profit, not-for-profit, public, private, are all converging to create new business models for this delivery, and that's appropriate because, you know, if anything we all take away as well is there, you know, there are no silver bullets or fast fixes to any of these tough problems, because with all the, if there was, you know, people here would be doing it because there's enough commitment and there's enough concern. And so I think what the convergence is giving us now some new tools, new business models, new ways to think about partnerships that show a lot of promise for moving forward.
Yeah, I think it's true and well represented at the forum. And at the same time, I think for this conversation, when you talk about the very poor, a lot of times you also think of a clear role for subsidy and for government. So Dr. KRISTIN, we're very interested in your perspective. And you can speak as a doctor who has experienced what I imagine is the anguish of losing a patient to preventable conditions. And at the same time, you are uniquely positioned to have a perspective on the constraints of government to be able to deliver services to its citizens. So can you share with us a little about your perspective, given both of those roles?
Thank you very much. From a medical background, I'm an obstetrician and gynecologist. So my life has been spent really dealing with the end outcomes of non-availability of services, lack of access for most women. And so my focus really as an individual has been to focus on women's health and trying to connect the dots of improving women's health by various stakeholders. And you know, as a provider, it was always very frustrating, and you know, having to deal with women coming in with highly preventable causes of morbidity, But the main issue, the main barrier for them, for most of the women, is the social, cultural barriers. Because of the subordinate status of the women in African societies, women are not perceived to make decisions, even decisions regarding their own health. And it's very frustrating for providers to, to look at women and trying to get the story of their delays coming to the hospital, why they have delayed coming to the hospitals. And so when I became First Lady, I had all these pent-up frustrations within me, and I thought being First Lady would actually make me trying to tackle these barriers to health services. But I was quickly disillusioned because the donors didn't want to do anything with me because I was perceived to be government, and government also was quick to tell me, oh, you do not have a constitutional office. So, really you can't get funding. I had the ideas, I had the voice, but I couldn't navigate my way through. So, and because of that, I guess I turned more to partnerships, to really looking at how I could be able to form coalition on health and for better outcomes. For a long time, we've had a fragmented approach with donors coming in with their own vertical programs, making it, with very limited dialogue space. But recently, I think there's been a rethink of how government should be able to spread and reach the very poor with basic services. And for health, they've really anchored the framework within the health systems, the WHO health systems approach, which looks at service delivery, infrastructure, healthcare financing, health resources for health, and leadership and governance. And they're trying to encourage every stakeholder to really buy into there and encourage horizontal programs so that you strengthen the system to be able to be responsive, to be more responsive to the poor. And thus maybe trying to increase the coverage. And we've had discussions within government circles where the strategic framework or the strategic plan was actually based on this health systems principles and anchored within universal health coverage for all. And based on that, integration has been identified as a main drive for increasing coverage. Initially, I think when we started thinking of scaling up programs, we were thinking of reaching more people. But now the perspective has differently changed. We're now trying to reach more people with more services at one given time. And we've had now to start thinking of decentralizing services. So in addition to the static health services, one innovation has been to use the mobile health clinics. And the mobile health clinics are actually a group of vehicles, and we have the specialists. So we actually improving the quality of healthcare and the availability of health services. So they go down to the rural health centers, because what tended to happen was in the static services, the people who were utilizing the services were not the poor. It was usually people who could afford. We have a principle of free primary health care, but that did not take care of the user costs at the point of service. So, people had to buy their own drugs, people had to buy commodities and so on. And it also became increasingly quite expensive for the poor people to access the tertiary and secondary level of care. But taking the services now back to the community, as NEAL said, with the people-centered, community-centered health program, you are assured of actually having a greater impact, because what that does is to increase the voice of the poor people, the end users that you are targeting. Yeah. It also helps you raise awareness on a lot of conditions, and it also increases utilization of services just as you go much, much lower.
Which is so important. And one of the things you mentioned was making sure that innovation is being fed back into the system. So a lot of people that are at our conference this week are thinking about the path to scale for their approach or their model as being government adoption or government embedding their modal. Does that really happen?
I think it's extremely, you know, I'm glad you actually brought up the involvement of government, because if we actually thinking of going up to scale, we've got to think of whether we're going to do a smooth scale up or a giant leap. But all the same, what is extremely important is that government has to take the leadership, because if you're talking of sustainability, if you're talking about the issues of equity, government has to be driving the scaling up. And so, you know, it makes it much easier to have all the stakeholders coming in. I know there are always issues of accountability, issues of whatever, good governance, but I think when you have planning, when you design a coordinated, well, if you have an all-inclusive planning design for scale up where you have all stakeholders being involved, it makes it much easier to understand and also reduces the tensions between the different stakeholders, especially the non-state stakeholders and the government stakeholders. And in Zambia, I think it has worked quite well, because right now we have one budget for health, and everyone is buying into the National Strategic Plan. We have one M&E, and other stakeholders are welcome to develop their own add-on M&E for their own purposes, for their own reporting back to the donors. But it works quite well. So government has to be in the driving seat if we're actually talking about scaling up.
Especially to reach the poorest of the poor. So I want to open it back up to the group for a second and follow up on something else the First Lady mentioned, which was demand for services. Sometimes we think about the need and assume that means that there's great demand to access the services that actually could have an impact on issues like healthcare. How does everyone or anyone think about demand as it relates to your work?
Well, I'd start by saying we're pretty obsessed by it. And I'd say more broadly that I think the larger work of global health and development as a sector, I mean, it was very much the sort of form we see it of today, both at the large and small, is sort of post-World War II sort of crisis model that was sort of structured around fundamentally Washington, London, and Geneva at that time, deciding what the Global South needed, identifying sort of on a supply side model, and then setting up an infrastructure for delivery. And the reality is while some of that still exists, and certainly there's times when, you know, direct intervention is required in humanitarian crises or fragile states, that most of this is shifted to, you know, country-driven political will, political capacity, you know, really strong thinking on the country side, from the perspective of, you know, various countries around the world that still have lots of needs. But so from that perspective, I think the whole thing has to shift to a demand-side model, and that means literally understanding better what the government's priorities are, literally getting down to design-driven, I mean, customer-driven designed issues, really doing a lot more. I know in our group, even since I've started, we've actually had to bring in a lot more literally health economists and people to help understand the cost and formula, the model. We're doing 2 projects just quickly in Zambia, which are quite interesting, on a very much demand-driven, but to the First Lady's point, at scale. One is taking existing tools, and literally it's maybe one of the countries in sub-Saharan Africa that we will see a malaria being eliminated by a very aggressive but very much driven with the government under their plan and the demand they've created around, okay, here's a bunch of interventions, but we have to redesign the way we go about it. And the sort of the big theme there is, instead of just tackling it with symptomatic patients, is going after the whole reservoir of malaria infection in a catchment area using new tools and technologies. But that's really been driven by the, you know, insights from the Zambian leadership less so by us coming in with a bunch of new tools. In fact, it's very little. And similarly, the Zambian government's made a huge commitment to reshape their whole data around immunization. So in a lot of countries where there are no birth records, or most kids are born outside of, in their homes, there's no birth records. So the first contact a lot of times people have with the government is their first immunization, which is pretty high in some countries. So that becomes a proxy for a register. So we're actually working very deeply now with the Minister of Health of how to create a demand-driven, kind of model, but actually using architecture and structure that is actually we've learned from other places around the world.
Does anyone else want to comment on that?
Just real quick, I've used an interesting analogy, which is I think the banana versus the persimmon. The banana, I did some supermarket consulting once, and the banana is a top-selling item in the grocery store. It's a wonderful product. You take it, it's shelf-stable, it's been ripened to exact perfection. You unpeel it, you don't have to, it's not messy, and you eat it. The persimmon, on the other hand, is, I would say, far more delicious, but also extremely difficult to operationalize for the supermarket. People don't know what it is. It's very squishy and messy and things like that. And similarly, as with fruit, with any kind of product, we really believe in product configuration and making sure it's appropriate for the people that we're trying to serve. An example, which of course Path is the master at. An example would be trees. I think when most people think about growing trees, they think about these very elaborate nurseries and very complicated ways of growing trees. But we think that there's a way to grow, for farmers, to grow trees from seed. A tree could be thought of as like any other crop. And we think that if governments wanted to scale up tree growing in their countries, that they should consider a different path. So for us, we have farmer trials with 1,000 farmers, 10,000 farmers, growing trees under many different configurations to try to make it possible for the most average, boring, low-skill smallholder farmer to grow an amazing crop for their country.
Mm-hmm. Yeah, and what I would say is, insofar as demand is a proxy for what people see as their own priorities, it's absolutely essential. But on the other hand, we also know that, many places, really poor people, the prudent thing to do is be very conservative in your investment strategy and what you're doing. And so someone may not immediately say, oh, I would love to have a risk insurance product because that will help me take more risk to invest. But when you can, introduce that product and work and explain, that, okay, now, well, in a place like Haiti, we hope an earthquake's once every 300 to 500 years. But every year, like in so many places around the world, storms come through and destroy assets. But if you knew that you had some way to replace those assets, right, if they got destroyed, you might take a little more risk in your farming strategies, which might, hopefully, would lead to more income. And there, I think, just like conditional cash transfers, where you're trying to encourage, healthy behaviors in a sense. People kind of know what those are, but I think since we're here at Oxford as the economists, but I think aligning incentives in ways that stimulate that kind of demand really are important tools that I think we've all come to use.
And I think it's actually very important. If you're going to go the way of the demand model, that information sharing is extremely important, because a lot of the poor are not aware of what their rights are. They're not aware of even what conditions they, would affect their health outcomes. And we've seen this in Zambia in the case of cancer screening services. It was really very difficult to start explaining to poor people what a cervix is. And it's a reproductive health organ, and there's a lot of taboo and silence around the issues of reproductive health. So it became very difficult for us to even start explaining and for them to comprehend the enormity of the burden of cancer of the cervix, which in Zambia, incidentally, Zambia is the second highest, having the second highest prevalence of cancer of the cervix, and is killing a lot of people, kills about 1,600 women every year. So when we started talking about creating demand, we actually did realize that knowledge was absent. When we started talking about ending child marriages, people were not aware of who the child was. So we had to really get down to start raising awareness. And we did it through different models, working with the traditional leaders who have proved to be really a critical factor actually for scaling up, because they are an influential voice and they tend to model a lot of behaviors in the rural areas. And what we have seen now with the cancer screening program, is the fact that awareness has been raised. There's so much demand, and that demand is actually holding accountable government to be able to push the programs to where the people are. People are phoning in, people are holding their members of parliament accountable and say, you know, if you don't bring the services here, we're not going to vote for you. And this is what the power of just information sharing has done. In addition, the use of ICT has also revolutionized how people perceived healthcare services. And this is also with cancer of the cervix, because to explain the cervix, we had to bring in computer technologies, using a camera. You know, we're using visual inspection using acetic acid, and we're not doing the pap smear screening. So the nurses, the mid-level nurses, apply vinegar, just home vinegar on the cervix, and then you start waiting for the changes. The changes are captured on camera, and the photos are uploaded on a computer. So it becomes very easy to tell the women, this is your cervix. You know, this is, your cervix is normal, or your cervix is abnormal, and they're able to actually appreciate the abnormality on the cervix. And we've had instances where people now, women, even uneducated women who were not even computer savvy, coming in with flash disks, trying to get hold of the photos, and they are using those photos to be able to monitor the progress. They are using those photos to be able to go, when they are referred to a hospital for treatment, they are able to identify and say, no, that's not my cervix, I've got my cervix here. This is our... And because of that, you know, the confidence in the health system has really gone up. You know, because hospitals started, after the removal of the user fees, you know, utilization went up, but that actually put a lot of pressure on the health facilities, because, you know, facilities started competing for drugs, human resource, no incentives, and so on. And, you know, people would go to the hospital, they would see a doctor, but nothing would be given to them. So they lost the confidence in coming to the hospital. They actually started calling the hospitals as transit homes for the mortuary, you know. But using technology, they've started now associating and actually appreciating what government is doing for their cause.
Seeing is believing.
Believing,
right?
yes.
Just think about that in the era of Twitter.
Yeah.
So, Andrew, following on the idea of supporting government, you've started to think more recently about government service. Meanwhile, we just watched a video that showed everything that you do in your bundle as a link in the chain. So what does it mean to think about unbreaking those links somehow? It seems almost like social entrepreneurship, postmodernism somehow, deconstructing it. So tell us how you're thinking about that.
Yeah, absolutely. I think someone put it very well that government has incredible reach. It's the kind of reach that we could never hope to achieve on our own. And we have to find ways. I really do believe that farmers, for example, need to put together many components to actually truly access products. But there are many situations where I think government is doing a pretty good job. They've managed to get delivery working, to get people to partially afford stuff. There's some element of training out there. And so my organization, for example, is often now taking learnings from the field and working in support of governments to assist them with improving their training regimen, or getting in touch with their extension workers. Maybe they have 10,000 extension workers and they need to be able to SMS with them regularly. Or maybe fertilizer delivery is okay, but it's maybe not really getting into the rural areas. So we can help set up hundreds of rural drop points to assist government with their vision. So we're seeing wonderful opportunities where government is already doing a pretty good job and just has incredible reach. And behind the scenes, we're hoping to kind of help provide a little bit of support to help support the vision they have for their people.
So just to follow up on that, I think in this space, when a lot of people think about working with government, it's often to be a technical assistance provider to government, but you are still the direct implementer in how you're partnering with government.
Yes, I think it's been really wonderful to find situations where, we don't have to just drop off a PowerPoint. We do that too, though. We're very good at the PowerPoint. But then we also get to work in the field, hand in hand, together with governments. And I think that's where you really achieve real delivery synergies, in my opinion.
Anything to add? Anyone else? No. So why don't we open it up for questions now? As a reminder, please wait for a microphone and restate your question. Yeah, how about right here first?
Thank you. Good morning. My name is Abigail Kaindo. I really feel at home to be with the First Lady. I'm from Zambia. Yes, my question is, Your Excellency, how are you engaging the young people, especially to delivery service with particular attention to the rural areas? Is there a plan for capacity building? Thank you.
Do we take more questions or I answer?
Why don't you?
Okay. I'm glad that you brought up that thing, because one of the issues I'm actually trying to actively advocate for is the involvement of the youth. And I had a very nice time trying to engage with them on the discussions on the post-2015 MDG. And it was very interesting that, what was coming out from the youth. They wanted education, they wanted jobs, and they wanted better health care. And I've been trying to mentor them, to see how best they can get more involved in the development of Zambia, as opposed to waiting for government going to them, trying to get them to start identifying the opportunities that are prevalent and see where they can, they can find their niche. My office or my organization actually signed a memorandum of understanding with UNDP, trying to, to scale up the mentoring program for the youth. In terms of reproductive health as well, it was very interesting working with the youth in trying to increase, to get the HPV vaccine to be accepted within Zambia. We currently undertaking a demonstration project of HPV, hoping to go up to scale once we learn lessons from here. And it was the youth that actually took up the mantle to go and talk to the parents, to go and talk to the churches, and going to talk to the traditional leaders, even in the face of controversies, in the face of a lot of parents hesitating to get involved. The children started getting to demand the services. We had used an approach, an integrated approach, a holistic approach, where we are not just focusing on HPV, but also broadening the sexual reproductive health education and sexuality education. So there is something that is going on, and the government, the president himself is very keen to make sure that the youth do get involved in the post-2015. So maybe as a youth, you can take it up so that we don't lose that focus on the youth in the 2015 post-agenda.
Great. So why don't we take a few questions this time? Josh?
Hi, everyone. I'm Josh
I know who you are.
Josh Nezza from Medic Mobile. So we think a lot about scale and equity for our products and tools. And I'm curious if you think about that as well, and what percentage of the citizens and people and the target population is good enough for each of you, and how you decided that with regards to investment in marketing, education, training, and delivery.
Great. Let's take two more. We go right here first.
Hi, I'm Erica Tavares from International Medical Corps, and I appreciate both Neil and Steve's comments about sort of needing to continue to drive innovation in organizations that have been around for quite some time. And so we just also, sort of building on your question, love to hear what you what you think the role is of organizations like Mercy Corps and like PATH in working with social entrepreneurs to bring innovations and new innovations into the field of healthcare, and how you see your organization's role in that.
Great. And then one more right here.
Great. Thank you. Shari Barenbach from the U.S. Africa Development Foundation. When we have these discussions about the healthcare systems, I think that one of the backdrops or one of the elephants in the room is really a position around the positive value of universal healthcare as it contrasts with the capacity of many African governments to actually deliver that healthcare, particularly out to more remote rural areas and communities, where, just as the First Lady was commenting, how in many rural areas, if you go to a clinic, it's rare for the doctor or the clinician to be there on a regular basis. There may not be medications, may not reach there. So and I'm just wondering the pros and cons of pushing for universal health care versus more of a value chain approach to healthcare and health systems development and delivery, so that you're looking at, private actors and multiple kind of characters helping to bring about more robust supply chains and really getting that healthcare delivery taking place.
Great, thanks. So we have, how do you think about the right number with scale? What's the role of Mercy Corps and PATH in linking social entrepreneurs and innovation in your organizations? And then how do you think about the trade-offs in capacity and coverage?
I'll take a first quick crack at it, trying to tie the two together. And for Mercy Corps, it's a little different. I'll give you two quick examples. So in a place like Indonesia, which is obviously a strong emerging economy, 50 million people have access to financial services, 40 million don't. And so when we looked at that challenge, having been there for a while, having worked with a lot of the microfinance institutions, the answer clearly wasn't bring in Grameen or create another retail institution, because you're never going to close the gap to 40 million just by adding a bunch of retail. And so was there something in the ecosystem that could stimulate, new responses, but also commercial responses to really try to close the gap? And so what we looked with Gates funding in this case was creating a wholesale bank, building a technology platform that would tie together the strongest MFIs, say the strongest 5,000 among 50,000, right? That could then go to scale quick. And on that platform, you could introduce new products and services that are more cost effective, right? So that's the way we thought about it. But it was, really tweaking the ecosystem, and maybe more than tweak, that may be a little bit of an understatement, but major investments in an ecosystem that could then respond over time to closing the financial inclusion gap, as opposed to a scaling of a retail sort of solution. Then in areas of conflict, which are most of the areas where we work, and it's really, it's either in a part of a country that maybe there is significant competition over resources, but that's located in 10 or 15 villages. But if the conflict were to break out there, it has the potential to spread and could then undermine economic development progress, quality of life elsewhere in the country. So for us then, it's really targeting in, and then, and then it's a little bit relative on the numbers. What is a tipping point when you're equipping those communities both with, reinforcing traditional methods of dealing with conflict, introducing, some newer methods of dealing with that, undergirding it with economic development, so you create positive incentives for whether it's religious or tribal or clan, whatever the source of the, or inequality, you're undergirding it with economic opportunity and giving people positive incentives to, to see a common future together. And so even in a place like Afghanistan, where we work with, thousands of smallholder farmers, adding, it's interesting in the way a lot of you all might think, well, how do we add more? We think you add 10,000 more and Afghanistan collapses, that's going to undermine all of our efforts, right? And so it's what is being significant enough to create a farmer's voice with government that encourages transparency, encourages accountability, and puts pressure for hopefully things to stay more stable. And not to be Pollyannish about it, because there's not, you know, but that, you know, in so many countries, that's the way that we think about that. And then in terms of working, you know, with social entrepreneurs, and this is, and I'm, you know, appreciate you asking that question, because, you know, I do think we've had, you know, in sort of the world of development, there have been the kind of larger traditional NGOs. Sometimes in places like this, they're viewed as dinosaurs, not by any view. And I think a lot of traditional NGOs have been slow to innovate, to adapt, to change their models. Then you've had this whole wonderful world of social entrepreneurship, that continuum from entrepreneurship to innovation to enterprise, which has been wonderful, which in many cases has wrestled with scale. So I actually think there's some great opportunities for partnership, you know, for some of the larger NGOs, and Mercy Corps is a smaller, larger NGO, but to put, you know, to really, you know, to take those platforms that are out there in so many communities around, form partnerships, and, you know, it's a way to bring in innovation into these, and they represent platforms, linkages with government, often linkages with the private sector, a lot of shared value partnerships, one of our newer buzzwords. But a lot of that is real, that I think give us together the potential to be better as a community.
Great. Anyone else want to add?
Well, just two quick things on those. One is reaffirming Neil's point. I do think the opportunity for shared learning and, you know, conversation about how do we, you know, that sort of middle of the value chain, if you will. There's a lot of learning and a lot of capability and a lot of it's sort of functional capacity that it takes to do that. And I think that's where, you know, great ideas and great new, smaller, you know, opportunities to say, well, whether you do it alone, you do it in partnership, et cetera, how do you help? I think that's a huge opportunity. Two other quick ones. I mean, first, PATH specifically, I mean, to be clear, we don't have proprietary products. These are not, we don't own these things. We work in partnership, and everything we do is in partnership, and fairly agnostic as to the tool or the model, as long as science will demonstrate what's effective and both cost-effective and efficacious around the problem. So we're actually always in the business of looking for innovation that actually really tackles these big problems and helping them scale it up, helping adapt it, helping it get to the right cost, into the right distribution channel. So that's actually part of what we do. That's how we see our work. And my only final comment is on, I struggle a lot with this on universal health care. I think it's the right political commitment, but I actually worry in the SDGs, the post-2015 conversations, that it's going to distract from the opportunity to create measurable, effective, you know, targets and indicators that actually we can move the needle against. Which I actually think we have some real careful navigation to keep the commitment to that's the ultimate goal, breadth, you know, both breadth and depth on universal health coverage. But we've got to come up with some shorter term approaches that are specifically ecosystem driven. Because you know, we can't do any of this without this convergence that Neil's talking about. And to do that, I mean, I've been in some conversations at the United Nations recently, how do we get the private sector more involved in the post-2015 MDGs, and I can tell you the language, I mean, just, you know, having been a CEO in the private sector for many years, like, you know, coming into a conversation about, you know, how do we participate in the post-2015 MDGs around universal health care, that's like the first way to turn away every private sector guy in the room. I mean, we're not even talking about it the right way to get the level of engagement we really need, so that's my worry.
I think it's actually important to also appreciate the role of the private health sector. That, you know, I mean, most of the times when they actually ask you to participate in the post-2015, you always think it's funding. But we've been trying to see how we can engage the private sector using their core functions, you know, to actually help reach out to the poor. We're talking with transporters to see whether we can be able to use them to distribute logistics and commodities in the last mile. And that's something that maybe people are not talking about. How do we increasingly use the core function of the private sectors to drive the health agenda within countries? as opposed to just expecting money, handouts, and so on. But there's also an issue of how to get the private sector to also be involved in countries with the social welfare assistance, which have proved to be very helpful in different countries, because we know government is not going to be able to do it. Many countries in Africa are struggling with competing priorities, right. You know, the disease burden, you know, the double burden of communicable and non-communicable diseases. And I think it's really helping bring the business model into the political model and trying to help governments push the agenda forward, so at least we have better health outcomes.
Great, thank you. We take a few more questions. Anne?
Thank you, KRISTIN. Thank you very much to all the panel. I'd like to make a comment and then ask a question. I'd like to make a comment about our experience as an organization. We work in Zambia. We have a very substantial education program in Zambia. And I'm a social entrepreneur. And I think sometimes social entrepreneurship is seen as a kind of movement that somehow bypasses mainstream, that bypasses government structures. And the reality is that most social entrepreneurs begin from a standing start with almost no resources. That was certainly my case. That was certainly CAMFED's case. And the Ministry of Education in Zambia invited us to work with them. It was Barbara Chilangwa, who's now ambassador to Angola. And we were provided with accommodation at the Ministry of Education. We were provided with vehicles. And so from the outset, and we were welcomed and included as partners in the delivery and in the expansion of access to education for rural girls, which was our priority and was indeed a government ministry priority. And that really set the tone for the continuing relationship, which has been profoundly beneficial, I think, to both, but more particularly to those we serve. And my question really relates to education, particularly education delivery in the rural areas, but I think this also does relate to the health sector and others. And that is, and you touched upon it, Your Excellency, the issue of the rural environment and getting services to the rural poor, and the need to, as you have all emphasized, to have, community-driven, demand-driven services. Most in Zambia and the other countries in which we work in Africa, most teachers are from the urban centers. They're deployed, they are educated in the urban centers, and they come to the rural areas oftentimes with reluctance, because rural young people are not getting to that point where they can go into professional jobs because they don't have the means. And this is a major barrier to the improvement of services, because you've got this constant rotation of people in the service itself. How can we create the environment, working with government, working with business, working with NGOs, the social entrepreneurial sector, to incentivize and enable, and I think the enabling is absolutely crucial, young people in the rural areas to go into the sectors, the health sectors, the education sectors, and to drive change? Because Abigail has spoken, and Abigail is one of the CAMFED alumni, and one of many. And what we see in the abilities, the capabilities, and the drive of the young people in the rural communities who actually get through is that they provide a quality of service and empathy for the rural poor that isn't necessarily.
That's a great question, Anne. We'll take one more. Here.
Good morning. My name is Chantal Heuting from iCare. We produce washable sanitary pads in Kenya. And what I struggle with is we really want to upscale our market, but it's not only about the products. What we also do is to train girls about menstrual hygiene management and to create awareness. But what we want to achieve is that the product stays affordable. So if you combine product delivery and training, from what we see, because if we want to go to the rural area and the remote area, it costs a lot of money to reach all those girls and to talk about those sensitive issues. So my question is, how can you combine something like menstrual hygiene management, which is a taboo in Africa, and a product delivery and upskill our activities?
So I think because some people probably are going to need to start leaving, please think about those questions, but also if everyone could share a closing thought on the opportunity that you see related to service delivery to the very poor.
We'll come into the question about retention of the much needed skills in rural areas. I'm sure you're also aware in Zambia piloted the issue of rural retention schemes, where the doctors that were going to work in rural areas were paid much more than those that decided to work in the urban centers. And government has also piloted the results-based financing for rural areas, where more money will be given to districts that are performing quite well. And that in itself serves as a motivation, because the health workers' input is being recognized and being remunerated, and they tend to stay much more. Education opportunities were much higher and easier for people staying in the rural areas as opposed to those that are staying in the urban. And this actually had a negative outlay on in health, because the young doctors who were being sent to the rural areas did not want to come back to do their postgraduate training. So we lost out on specialization. People wanted to stay in the rural areas because they were getting far much more than a senior doctor in the urban center. So we're trying to relook at all these issues and maybe trying to start thinking of a better health financing strategy, which is going to mobilize more resources and get more people getting into the rural areas, and that will include teachers as well. So it was tried for nurses and for the doctors, but I think it's opening up. I don't know, we've got somebody from the Ministry of Health here who might want to talk to that. Mr. Movita, on the rural retention scheme?
Maybe we can follow up afterwards and with a specific conversation there. That would be great. Thank you.
I have three quick ones. One is, I think we have to worry about how we define scale, because actually, to some degree, if you focus on scales and some interventions, you're going to move to the urban areas where you can do more quickly with less, without. So part of our issue about making sure we're inclusive is making sure that we don't over-define scale just in numeric terms, but also in relative terms. I think that's one. Second of all, I do think that we're learning the hard way that platform kind of models are actually, where you look at how businesses has managed scale and reach, it's often and managed to push cost, where cost management is platform models. So platform technology companies tend to do quite well, platform retail, consumer good companies. So one of the things we're trying to do is think about how do you sort of take an intervention and instead of keeping it siloed, pull it along against a platform of other services and activities. And so an interesting thing right now is with the heavy investment over the last decade by the PEPFAR, the big US government HIV/AIDS program that's created this huge sort of set of HIV-related platforms, but actually there now could be places that you can go in with a lot of, if we can get the government to loosen up a little bit, to enable using those as platforms for introduction of new tools and devices that may not be anything to do with HIV, but you're also reaching communities, and that's a way to kind of leverage and keep the cost down and introduce it at the communities. And I just would sort of, the third is, everything's got to get, we've got to keep reinventing this. We really have got to reinvent and reinvent and reinvent. And I think the most exciting thing happening is some of the young folks that we're working with are coming in saying, let's totally relook at this stuff. You guys have got to throw away your 10-year models and start all over again using an approach that's consumer-driven. It's using social media in new ways. And I think it's very exciting, and it's going to rock our world, but it's quite extraordinary.
I'm glad you actually talked about leveraging resources within countries, because for the cervical cancer program, we've actually leveraged the PEPFAR platform to integrate cervical cancer screening. And as we look at the mobile health centers, we are leveraging those platforms to, they were essentially curative specialized curative services, but now we are integrating the cervical cancer screening, we are integrating reproductive health services, you know, male circumcision, the numbers are really going up just through the platform of mobile health services, and it works much, much better. So you've got to start identifying platforms, existing platforms that are within, and leverage the resources to push the scale.
Andrew?
So in terms of like closing thoughts, a lot of us here work, I think, for really important funders and social enterprises, and I just wanted to give another plug that I just believe so much in the importance of delivery. I think that we have, as a society, theoretically eliminated poverty 50 to 100 years ago. In agriculture, most of the important scientific discoveries were 100 years ago. We can go to any poor person anywhere, and we know exactly how to solve every single problem that they have. So I think we tend to focus, I think we tend to over-focus on what's new and interesting. I don't think we focus enough on just the plain old straightforward work of getting this out in people's hands. So obviously this is a bunch of people interested in delivery, so it's kind of like preaching to the choir or whatever, but I just think that work is so much more important. It's all of our jobs to focus back at our institutions to bring that focus to delivery.
Yeah, and you know, I would certainly agree. I would say that, you know, my hopeful, optimistic side is I do think in so many places in the world, and fortunately this is the majority of places, you know, if you get minimally decent governance and where markets mostly work, progress is happening. That's where all of you can bring the delivery models. You can apply the, you know, the old lessons in more powerful, effective delivery ways. And we are moving forward. Where I worry, and then I'll quote an economist from Oxford, Paul Collier, I do think it is true. In those countries where poor governance, conflict, and extreme poverty all collide, you know, he wrote his book, The Bottom Billion. I do think there are 1 billion people that are remaining trapped, that we're not having progress against, that are living in the Central African Republic, that are living in Syria, that are living in many areas torn apart by conflict. And there, the approaches, whether new or old, aren't bringing about the kind of changes that we need. And so my hope is that we can increasingly find these lessons learned from places that are really tough, but more stable, and that we can bring that to that bottom 1 billion on our planet who are being left behind.
Good Aristotelian.
Madam First Lady, do you have a final challenge or thought for us?
No, just to say that, I mean, I think there's quite a good place for social entrepreneurs in health and developing countries. I don't believe developing countries are poor, but I think we need help on how to harness the existing mineral wealth and the human resource that we have. I mean, it was interesting to hear of the witness, global witness. Probably we need to invite those to come and help us really harness what we have. In the face of diminishing international and external aid, we really have to start focusing on what we have and moving with what we have to make sure that we reach the poor.
Thank you. So thanks to all of you for being here today and participating. There's not enough syllables in Oxford to express my gratitude to our speakers for being part of this conversation and being at the Skoll.org Forum.
Thanks to KRISTIN.
Yeah, thanks.
Great job.
Yeah, thanks.